advisors for giving me this opportunity to present such case. So I'll be presenting a case of a huge giant cell tumor where I did limb salvage surgery using a mega prosthesis, and I'll give you a little bit of background history of the patient before he presented to me. This was the patient. He complained of right knee pain and there was an osteolytic lesion. He had got an X-ray done at a Google setup and he was neglected. And this was in 2016, and later in 2017 he developed a pathological fracture. And he presented to another surgeon, and there he got it operated and plating was done for this case, though the pathology was neglected, and though told that there was little bit of delayed union, but in the end it united. And later he presented with a swelling which was diagnosed as tumor in 2019. The pain persisted and the swelling was increasing in size, and he was not able to walk, and he was walking with using the stick. So now he presented to me. So this was the case, and he was 27-year-old when he presented to me, and with a bony hard swelling in the right knee. The swelling was painful and progressive in size. He was not able to bend the knee and was walking with support. So this was the pre-op X-ray. Here you can see an expansile lesion. This was on presentation, and the plate and back out of the screws was also present. So I got a CT scan done, and these were the 3D images of the CT. Though because of the implant in situ, there was some the CTs were not very clear, and we cannot get a MRI done because the plate was SS and there was loosening of the screws seen, so we didn't get an MRI done. But we got a CT angio done to look for the popliteal vessels. The flow was good and the vessels were posterior to the tumor. CT guided biopsy was also done, and histopathology was suggestive of a giant cell tumor. CT chest and ultrasound of the abdomen was also done, and evidence of metastasis were not there. So in the end we planned for a en-bloc safe tumor excision and distal femur tumor prosthesis. Though the consent for amputation was also taken, and he was explained that if there is the popliteal vessels are entangled in the tumor or it is difficult to remove it, we may end up the patient in amputation. Though the vascular surgeon and the plastic surgery team was also in the loop during the surgery. So this was the tumor which was excised. The femur was cut 4 cm above the tumor. The total femur which was dissected was 165 mm. The proximal margin biopsy was also sent, which came out to be negative for any dysplasias. So this was the tumor, 165 mm was cut. This was the implant. It was an Indian made implant which was used, and a knee hip spacer of 90 mm for maintaining the length, and as we know that the femur condylar length was 70 mm and the collar which the femur has is 5 mm. So the total was 165 mm, which was made on table as it was modular. So these are the intra-op images. Medial parapatellar approach was used during the excision of the tumor. Proximally the femur was cut and the dissection was done proximal to the distally, and after removing the femur the tibia was prepared, and it was fixed using a cemented implant was used, and it was fixed in the shaft. The rotation, it is important to maintain the rotation of the implant for correct patellar tracking. So the closure was good, the muscle repair was properly done, and the mechanism of the tumor was a hinge tumor mega prosthesis was used. These were the intra-op flexion and extension views. These are the post-op X-rays showing the good position of the implant. There was good fit proximally, and this is the post-surgery walking video. Weight bearing was started on 12th post-op day on suture removal using a brace. Knee brace was used for 1 month, and only 0 to 30 degree of bending was started at 3 weeks, and slowly it was progressed. This is the immediate. It is the 12th day walking video when first it was started. Seeing the functional outcome at 6 months. And yes, this was the 1 year follow. He is able to ride a bicycle at 6 months, and this is the walking video at 1 year of the follow. He is able to climb stairs. In most of the places, he was advised amputation, and this is the recent follow-up, 20 months. This is 2 to 3 days back. He has good range of movement, 0 to 80-90 degrees flexion is there, and full extension is there. And at 20 months follow-up, this is the walking video. He came to me riding a bike for around 40-50 kilometers to show me in a peripheral setup. Post-operative biopsy was also sent. It was suggestive of an aggressive giant cell tumor with little dysplasia. So post-operatively oncologist was also consulted. Few cycles of chemotherapy with denosumab was given. And I would like to acknowledge the plastic surgery and the vascular surgery team which was present in complete duration, and during the removal of the tumor was also present to guide me, so that if any vascular injury occurs, they were there to repair it and treat it. So the take home message is tumor processes can be a good limb salvage option with good functional outcome. Femur replacement gives better results compared to tibial replacement. Studies suggest that implants last for around 5 to 10 years in 85% of the cases. Ortho-onco surgeons should always be consulted if dealing with a malignant tumor, because we have to remove a sleeve of quadriceps and around the tumor, so that there is less chances of any metastasis and recurrence. Patient should be counseled about the longevity of the implant, revisions required at the later stages, high chances of infection, embolism, and also the need of amputation as a last resort. Thank you. One of the video didn't work, but I would like to share it because even I was not sure, and he was riding a cycle, and I was not expecting this good movement, and he is able to ride the bicycle at around 6 months of the follow.
About his stair climbing.
Yes.
When you see him on the stair climbing, he's climbing downstairs, but he's leading with his bad leg, so he's not able to flex his other leg when climbing on the stairs. So he's unloading his right leg going down the stairs. So what might that lead you to think?
Pardon?
When you see him coming down the stairs, he is leading with his bad leg, and he's not flexing his knee as he walks down the stairs. And similarly, when you can see him walking, he has a slight abnormality, and he's not really walking with this normal flexed gait. So what is that leading you to think about this case?
So the initial, in the initial follow-up days, I felt there was slight lengthening of the right leg compared to the left. That's why he used to, but in the recent follow-ups, whenever I see him, he is walking properly without any lurch. But in the initial setup, I felt that there is some 1 centimeter of the lengthening is there, because of which he was walking that way.
Okay. So I would think that there's probably a slight external rotation of the component, so that his patella isn't tracking exactly correct, and that's probably why he has the difficulty with the stairs. The leg length problem won't cause that. And secondly, can I ask you, why did you non-weight bear him after the surgery for 12 days?
So just for the muscle healing, basically, because I felt that there was extensive dissections done, so I felt that initial days, if we go just for the muscle healing and suture healing.
Okay. So I do these cases as well all the time. I weight bear them from day one. I don't non-weight bear them, and furthermore, I don't restrict their range of motion. As long as I'm happy I've got good tissue closure, I mobilize them straight away, fully weight bearing, and I start their range of motion immediately. If you leave these cases too long before you move them, they get sticky, they get adhesions, they can't get the range of motion. So really, it's critical to get a good rehab in these patients, early weight bearing and early range of motion.
So you said many of them are suggested amputation. So giant cell tumors are usually amenable to treatment. I don't think there is any role for amputation. Second thing, massive tumors close to the vessels, we start them on either denosumab or zoledonic acid pre-op. So it will cause some shrinkage and fibrosis of the tumor. It's helpful for dissection of the tumor. That is also one useful tip. Otherwise, well managed case.
Yeah. My question to the panelists are, how far do you think if the balancing is okay, even with the mega prosthesis, what do the role of non-ambulation leads to the healing of the soft tissues? Because sometimes if the balancing is okay, I think the movement makes healing more good rather than.
You need to keep these patients mobilized as quickly as possible. So this, which I could not understand, is why did you give denosumab at the end of your surgery, post-operatively? There is actually no need to give anything.
The histopathology report came as...
No, histopathology is giant cell tumor right from the start, right?
Yes,
so if you had to give denosumab, you had to give them prior to your surgery, not after your surgery.
So the pathologist suggested that it was a highly dysplastic tumor with the dysplastic changes are high, so we consulted the oncologist. So he suggested that post-operatively, to prevent recurrence, we should give denosumab. So,
okay. For how long?
Sir, they gave for 6 months, and they are following it up even now, the patients.
So that is one thing. The other thing what I want to ask from you is, intraoperatively, how do you judge whether your prosthesis has correct rotation vis-a-vis the hip?
Sir, usually we see the linea aspera, but the best thing which I felt, this was my first done case, and I had assisted once before. So basically, when you do the trial, during the trial, if we are getting the good range of movement and rotation is correct, we try to mark it, and during the fixation of the implant, we coordinate with the trial part, and we mark the femur part basically so that the rotation is correct.
Right. I think this is doing it the wrong way. Before you cut, not trial. Trial is after you excise the tumor.
Okay.
So before you cut, you know exactly what is anterior, right? Before you cut, you know what is exactly anterior because you've got the condyles with you, right? So make sure you mark at that point. Make 2 lines. So one is longitudinal, the other is 90-degree transverse to it. And that transverse line is the section level for your tumor. So you cut your tumor, you've still got that line there. Now you've got 2 lines, one is the cut line, one is the anterior longitudinal. You have your orientation.
So the tumor was also very huge, so it is very difficult judging it intraoperatively.
I have a question to Dr. James.
Was short.
Yes, you told you are frequently doing these kind of cases. What is the long-term follow-up of these cases? Because what I have seen in most of these cases, the prosthesis gives away at the junction of the stem and the main augment part. So you are allowing your patient to ride a bicycle also and climb stairs so frequently. Are you happy with that? I won't allow my patient to do that.
That's what I was saying, that I didn't expect he will be doing. He was from a rural setup, and he only sent me this video. I didn't ask, and I always have cautioned him about the safety of the implant so that it at least lasts for around 10 years, because the longevity part, even I am very skeptical about it.
So Dr. James, what's the long-term fate of these processes?
Yeah, so the vast majority of these cases tend to be done in older patients, because they're done for trauma or infection. When they're done in a young patient like this, a lot of surgeons now will be going towards trying to use uncemented stems to get fixation in these cases, so that you get a better outcome for long term. But if you're using cemented prosthesis, you'll find that over time, no matter what, a cemented prosthesis will loosen. I've seen many of these done in my institution. I don't have enough long-term follow-up in mine. Mine are done maybe 10, 12 years at this point, some of the early ones, and I haven't had to revise the early ones yet, but certainly in a younger patient, I would be thinking about using a cementless press-fit stem, because those patients are more likely to loosen and need something later. So it's dependent on the type of fixation in which patient. That's the way I would think about it. On average, a cemented prosthesis, well done, you might get 10, 12 years out of it. That's what the literature would say. So,
My one question to James: how is the policy of treatment in your country in comparison to India for these cases? Because they think that the amputation followed with the just to ambulate the patient earliest.
so you're saying
The policy of treatment of this tumor in comparison to the limb salvage and amputation.
so for hello? Yeah, so the vast majority of cases in these ones that I do, I tend to do cases for metastatic disease, I tend to do cases for infection. We have a policy in our country that these cases are done, which are purely oncological cases, we do them in an oncological centre. So we have an oncological centre with specialised oncological surgeons who do these cases. Because we feel that having these cases centralised with one experienced surgeon gives a better outcome for the patient, rather than somebody who's not experienced in doing these cases regularly to be doing them. So firstly, in our country, all of these are centralised. Secondly, in terms of if I have to do a tumour prosthesis for an infection or for metastatic disease, which isn't a primary tumour, I don't have a problem. I'm able to do these cases when I want and how I want, thankfully, because I work in a tertiary referral hospital, so these get sent to me and I have no choice but to do them. They can't go elsewhere.
Thank you.
Sohan.
My question to Dr. Hartison. Sir, how do you decide?
Yeah.
This is that, yeah. How do you decide the length of the femoral stem in such type of cases? Length of femoral stem in such type of cases.
So checking the length of the stem is very important. I make sure that I drape the two legs freely so that I can check the length of the other side. And I will always measure what I take out. So whatever I remove, I will measure that, so I have an idea of what I'm.
I'm asking about the length of the femoral stem. It should be shorter. It should be longer. Sorry.
Yeah, so the intramedullary length of the stem. And so as much as possible, that depends on the bone quality. If you've got very good bone quality, you don't need to be worried about length. But if you've got poor bone quality, then I think I'll be looking for more fixation. I make that decision intraoperatively, and you have various different types of lengths. I'm trying to maintain as much of the quality of the bone as I can, and trying to avoid, because you know that in time you may have to go back.
I think there are only two options for the cemented stem, either 100 or 125. So 100 is adequate. If it's very osteoporotic, you can take it to 125. Using uncemented stem, you have options because it's going to stay for a longer time.
Yeah.
Go longer.
Good. Dr. Vineet Yadav.
Okay. Very good morning, everybody. Without taking much time, can we have a didactic sort of presentation? Amit sir, Kapil sir. Okay, great. So I am presenting two of my cases. So these are done with sleeve management. These are revision knee surgeries. So this was a so-called young 88-year-old lady. She was operated 15 years back, and she was walking and doing everything happily. And from last 6 months, she was not able to bear weight. There was no as such swelling in her knee. She presented to me with this accident. So, can we have opinion of Kapil sir? You are quiet for some time. Can we have your opinion for this?
Can we do that at the end of the case presentation?
Yeah, well,
Finish the presentation and then we will discuss it.
Great. So this was the X-ray with which she presented to me. I got her all investigations to rule out any infection in that, and after that I got a CT scan done. So due to the metal artifacts, I couldn't get the best picture in the CT. This was the picture which I could get. So I found out that the medial epicondyle of the femur was intact, and literally it was some doubtful thing. The tibial component was all okay. So I planned for the revision surgery of this knee and zone at least two zone fixation in the femoral area with the standard tibia in this, either a cone or a sleeve with a stem and the femoral component the regular one. So this was her during OT video. So knee was quite lax. So the varus test was too much laxity. The valgus it was not that lax. So when we opened the joint and the MCL was intact, the medial epicondyle was very much intact. The LCL was also intact in this patient Parov, and the knee was quite stable. So we used a femoral sleeve in this patient and did fill the gap remained after putting the sleeve with the cement and did put a stem over that with two zone fixation in femoral area and two zone fixation in tibia both. So this was her post-op X-ray, and this is her 1 month video walking. She was 88-year-old lady at that time. The right knee was operated. And unfortunately, after 6 months, she again fell down and had fractured neck of femur. We counseled her for a total hip, but she was not ready for that, so we went ahead with the cemented bipolar processes in that. Still, I am a bit worried about the stress area between the stems of femoral processes and the tibial femoral stem. So this is one of the case in which I managed the defect with the sleeve. So the second one is a bit interesting case. This was a young male. He had a lax knee with grade 4 osteoarthritic changes. He came to me with this. It was done somewhere in 2017 or 16. And this was his post-op X-ray. It was not the best done knee. The left knee was in varus, the tibial slope was reversed in both the knees, and as expected, it gave away in due course of time. So the left knee gave away within 6 months, and then I revised the left knee with tibial stem and semi-constrained TC3 insert in that. The femoral component was left as such, it was not revised. So this was his video 1 month after the revision of the left knee. The right knee was still in the same condition. So in due course of time, within 3.5 years, right knee also gave away. So he came to me with this X-ray. The tibial component was going medially, it was overhanging, it was painful. All the markers for the infection were alright and within normal limits. So I planned this with a sleeve in the tibial component, and MCL was intact. A semi-constrained knee with a TC3 type of implant was done. This is his right knee at 4 years of follow-up, and this was his 6-month follow-up of left knee. This is a walking video after 6 months, and this is his 2-year follow-up picture. Unfortunately, I am not having his video at 2-year follow-up. So these are the defect cases where we can manage the defects at the zone 2 metaphyseal with the metaphyseal sleeves or cones. I find sleeves are better as compared to cone because cementing is a big issue in putting cones. So these are the 2 cases which I did in recent time. Thank you.
Can you go back to your first case? If you show the post-op X-ray on your first case, keep going. One back.
Yeah. Yes.
Okay. So what do you think of that X-ray? I mean, I certainly know what I think.
So it was managed with a straightforward knee. The sleeves were good. So I got good purchase. The LCL looked bit doubtful, but it was intact.
Yeah, no, there's no LCL there. It is not there. It's not there. I think you were lucky.
Yeah, it's been almost 3 years. I did it before COVID period.
Sometimes in an elderly patient, you will get away with it because they don't have enough demand on that knee, and you can see that patient is 88. Her demand on that knee is very low. If you do that to a patient in their 60s or their 70s who's busy and active, that will give you trouble, and you'll be back revising it.
You don't actually see a lateral epicondyle.
That's true, sir. But we were ready with the semi-constrained knee on table. But after doing all the tests on the table, we found out that it's to be good.
I agree. That's fair. But I think if you did that to a 60-year-old patient, I am fairly sure you'll be back in trouble fairly quickly. So it's okay in this patient, and to say in an 88-year-old patient it will be fine, I think that's acceptable. But I think in a patient with higher demand, I don't think he will survive. So.
The only problem I faced while doing this sleeve is that the sleeves are, especially in Asian population and in this zone, the bones are very porotic. So while hammering the sleeve, it got a splinter of femoral distal femur.
Yeah.
So I didn't circularize that. It united in due course of time. So that was the only problem I faced with this sleeve.
Yeah, you can put a sleeve in without cerclage. If you've got good fixation in the sleeve, it will be fine. I really only ever put a cerclage on a sleeve if I have a significant crack. It's rare that I have to do it. So putting a sleeve on without a cable is fine.
Any further questions?
Yes.
Done, Shekhar?
So for this patient, you did a bipolar also.
Yes, sir.
Go to the X-ray.
Yeah.
You could have used unscemented stem. No? You used a cemented stem.
Yes. So she was advised.
You are cemented.
She was advised for
cemented.
Cementing is not good. I admit she was somewhat around 89-year-old. Anesthetist refused to go for a press fit cementing in this patient. So I didn't do that. So it was a plain finger type first generation type of cementing was done in this patient. I admit that the cementing could have been better. There is a stress.
No. Uncemented fixation. You could have opted for uncemented fixation. The metaphyseal
I would
fixation.
say this is door type B or C type of.
I think with this collar stem, you can do an uncemented fixation. Avoid a stress riser between the two segments, because if you have a metaphyseal fixation, the chance of having in between stress riser and a fracture can be avoided.
So it's almost 3 years since I did this, sir. Right now she's happy, but I'm too worried also about the stress factor.
My question to James, one question to you, in defect in the femoral component or the tibial component, how you prefer to do the sleeve or cones?
Well, I think if you wait until my lecture in the next session, I can tell you all about that. I have a full lecture on sleeves versus cones. So that's my next lecture. I will speak to you extensively about that.
We'll wait.
Yes, I think we are closing the session. Thank you, panelists.
Just one word.
Sure.
The second case, Dr. Vinit, which you showed, I just want to put a word of caution for the femoral stem. You could have made, can you show the X-ray, post-op X-ray? So if you could have shifted the hole, the stem will not be abutting against the anterior cortex, because that is a point which can lead to a crack anytime. And because the femora are bent, so you can shift the hole and you can manage very well with that. So that's a word of caution, just I want to say.
Point taken.
That component is in a bit of flexion.
Yeah. So the tip of the stem
will
lead, if you follow it up, I can show you, because I point my fingers that way also. The time will come, you will see a bit extra bone formation over the femur, and then ultimately it will break.
Point taken.
The other thing is you use the stem there, and then you have to use and if you want to do that, you got already got your component there, you have made your cuts, and use the stem which is called.
So managing the stem, we all do nails, so we can manage it very well.
So I always fear about these straight stems, be it knee or be it hip.
Yeah.
So that's the big issue in
The principles hold true in tibia as well.
Okay.
You cannot have a eccentric looking stent in the tibial canal. So that principle remains same if you want to avoid stress loading. And friends, we will not break for coffee. The coffee is there, the cookies are there. We take your coffee and come back, and we'll have now I think one of the most interesting session where the knee talks will be given by the masters, and let's have a good interactive session after that. I hope there's no more lectures on this session.
Sure.
Okay, thank you, sir.
So tea and coffee is there, okay. There's one
To ask
question,
something,
one Dr. Ramshekhar.
Yes.
So this is a cemented sleeve or uncemented sleeve?
This is uncemented sleeve, sir.
This is the largest size or what is
Largest ones are available with me.
Okay.
Largest one. I could have, yes, that's a point nicely pointed out, sir. So I wanted to put a larger sleeve in this, but I was not able to get that on table.
Dr. Vinit, now in one knee, I think you have done TC3 without femoral stem.
Yes.
Yeah.
I didn't change the femoral component. That was standard PFC sigma component. I didn't change that.
Okay. Any particular reason? Because it may fail early if you don't.
It's almost 6 years.
Okay, then it's good.
Can you show me the next X-ray?
That's one of the unusual thing what I did, sir. I know that's not rational, and yes,
This one, yeah, this one.
So this is a standard PFC femoral component. It's being 6 months. He's walking over that, and he's more happy in this knee as compared to the other one, which I did with sleeve. He's more happy with this knee.
He is of opinion that never argue a success. That's the only thing.
So God is great sometimes.
So there's a 2-minute transition
Sure.
for everything to settle down.
Check it with a spacer, but initially I would just look at it like this. It should appear something like that. Now, how do you reach there is very important. So once you have made your femur and tibial cuts, then you remove the osteophytes. Start removing everything from the medial side, usually osteophytes on the tibia, on the femur. So as you remove more and more bone, you get more and more space. So over the years, one thing that has changed my practice is in joint replacement, I've become a bone surgeon. I touch hardly any soft tissues. So I'll come to this. So remove the bone, which is extra bone, you can throw it. Put your tibial component, the size that you want to take, and all the extra bone on the medial side. So you have to align this from the lateral side, on the medial side, posteromedial, remove that bone. That bone is useless, and that gives you more space, more balancing for a varus knee. Still you are not okay, your extension gap is not balanced. Look at the X-ray. There is a posteromedial osteophyte. That is the one you should remove before jumping onto any balancing, etc. So remove that posteromedial osteophyte. You can remove it right away, or you can sometimes make a provisional posterior cut and then remove the osteophyte from the medial side. That gives a release to the medial compartment. If that doesn't work, come back to the tibia, do what is called reduction osteotomy. So I am playing with only bone, as you can see. I have not touched any soft tissue till now, and I don't touch the soft tissue on 99% of my cases. Now, after doing all this, I'll end up here. Still, it is not a rectangular space. I'm not happy, and I don't proceed to flexion gap till I've balanced my extension gap, because flexion gap is easy to balance. You can only rotate the component, but extension gap is difficult. And you have options. If you've done all this, you have 3 options. You can do extensive mesial release all the way, take a long curved osteotome, go all the way down almost about 5-6 centimeters. You have to reach the whole sleeve. Very dangerous to me, because you can elevate it, but where it will heal, how it will heal is the problem. Pie crusting was a described procedure. I've done it only once. I will never do it again. I don't touch MCL because it's a very sacrosanct ligament to the knee replacement surgery. Rather, again, I will do a bone surgeon again. A medial epicondylar osteotomy is a better option. It is bone. We are a bone surgeon. We know how to get the bones healed. We don't know how to get the ligaments healed. So, I don't touch ligaments. I just touch the bone. So more often than not, if I'm stuck in this situation, I will do medial epicondylar osteotomy and not do the other two options. So this is a situation, extension gap looks good, and then I put my spacer, because finally spacer should give you a good feel, not just traction. It should look like this. When you put a spacer and you see on the left hand side and you leave it alone, it should not open up like this. I put a spacer, leave the leg in extension without putting any varus valgus, and if it is opening up on this side, it is not a balance. It is tight on the medial side. Also, when I remove the spacer from inside, and I'm finding it difficult to pull it out on the medial side. Medial space is still tight. These are the indicators that we are not balanced yet. It may look balanced, but it is not balanced. So these are the. Now I'll present some cases which will give you an overview of the kind of varus knees we see, and what is important in them. So let me come with first case. The severe deformity in a 75-year-old person. And I asked my juniors, what is the catch in this patient? Every TKR, there is one catch. Means one thing that you have to be careful. And particularly in our society, where all the implants are not available on the scan. You have to ask for implants. You have to ask for TCT. You have to ask for ticket scan. Normally they bring a routine scan. If you don't know the catch, you don't ask for this special implant, on the table you are stuck. So in this patient, yes, there are maybe not a very difficult knee appearance, because it's just a medial tibial defect, and I knew if I have a tibial base plate and a stem, this should not be much of a problem. Then I always do a long leg x-ray. If you have a standing x-ray, very good, at least a scanogram. Because a lot of these varus knees have a very broad tibia, both femur, not tibia. Tibia we do extra-articular, no problem. But femur we do intra-articular, and you must get into the habit of doing a long leg x-ray, not a scanogram, to see the shape of your femur. Almost 20 to 30% time it is significantly bowed. And if you don't take that into account and do a standard 5-degree where distal femoral valgus, you will end up with femoral component varus more often than not. And in this, of course, it was straight, so I knew the only catch here is the medial condyle is defective. You take a rod, build up the medial condyle with cement or bone, whatever you think. In an old elderly person, I just use cement. In a younger person, I substitute with the bone because a revision may be required. So a simpler case, looking difficult but simpler case. Now this is another case where it's not correctable. The previous one was not correctable, this is not correctable with a lot of osteophytes. They look very dangerous. They look very crooked, very dangerous. But as soon as there are osteophytes around, I have a sigh of relief. For me, it appears difficult, but it is a simple case. It looks very bad, but I know in my heart, I'm a bone surgeon. All those unnecessary bone I'll remove. This will become a very simple case. I'm not touching soft tissues. You just remove osteophytes. May not need any soft tissue release. Don't jump to soft tissue release in a patient where there are a lot of osteophytes. Remove all of them. If you have done the release first and then you take the cuts, osteophytes go away, the whole joint will become imbalanced again, and you will not be possible to balance it again. So don't touch the soft tissues till you have done everything with the bone, and in this case, remove osteophytes. Cut less tibia. Whenever there is a bad deformity or a lot of osteophytes, be very miser about cutting the tibia. Not don't take standard 8 millimeter, take 4 millimeter. You can always recut it. Because once you remove all the osteophytes, it opens up. And sometimes in our society, they will say, "Mere paas, I don't have spacer more than 15." And that's a funny thing. So varus knee again correctable. It is correctable means it's an easy knee. You don't need to do any soft tissue release if the knee is getting corrected on clinical examination. In this case, there is a lax lateral ligament. You can see there are no osteophytes, but it is a lax lateral ligament. Again appears difficult when the patient walks in, but it is a simpler knee. Any knee with osteophytes, any knee with correctable, which is correctable on table, is a simpler knee. Don't play with soft tissue there. Just go a standard surgery and you will find everything is alright. Only catch is cut less tibia, because you have to balance this knee finally based on the available ligament length. So sometimes you'll end up putting big spacers. So just cut less tibia and be prepared for constraints in a lax ligament knee like this. The third knee is the most difficult. Varus knee, not correctable. Patient walks into your clinic and the x-ray looks very novice. It looks like a very straightforward knee, no osteophyte, nothing. It looks simple, but it is difficult because when you do a hip knee ankle long X-ray, you find the femur is bored, the tibia is bored. So this is a novice looking knee, appears simple, but it's difficult. Why? Because you're going to make all the correction inside by in your cuts, and then you will end up with a space which is not rectangular in this case, because you're trying to correct the bone deformity by intra-articular cuts. That's why in these cases you have to struggle, do a lot of soft tissue releases and get correction. These are the only cases where you have to do soft tissue releases, if at all. Otherwise, most of the cases, I think 90% of my cases, I don't touch MCL, I don't do any soft tissue releases, I just play with bone and land up. And of course, in these cases, very important to be constrained. Whatever you may do, at the end of it, you may not be able to achieve a good balance and you may need some kind of a constraint. So these are three different needs. One, lot of osteophytes, I'm very happy. No osteophyte and correctable, I am still happy. But no osteophyte and not correctable, this third variety is the one that worries me more. And then there are extra-articular deformities. If it's a young patient, I try to correct the extra-articular deformities separately. I don't want to play with the joint or play with ligaments. Trying to balance ligament, what has happened in the bone is not my idea, except in elderly people where maybe they have to live for 10 years. Otherwise, I like to correct quite a lot of deformities, extra-articular by extra-articular surgery, maybe use a plate, maybe a little longer surgery, maybe additional trauma, but the joint is not meant to play with soft tissue. You can't play with soft tissue and correct bony deformities by soft tissue. Theoretically a good idea, but practically, particularly in young people, not a good idea. So more the deformity, cut less tibia initially so that you don't open up, and keep constrained options available. That's the message I want to give for bad deformity. And this is a quick algorithm I would like to give you. So when you have a varus knee, you see correctability. If it is passively correctable, no soft tissue release ever. It is not required. Don't touch your MCL, don't do any releases, just do normal surgery. If it is a lateral lax ligament, as I showed in one other case, just cut tibia conservatively and you will find everything will fall in place. You will not need any soft tissue release here. If on the other hand, there is no lateral lax ligament, it is medial tibial or femoral condyle which is eroded. Again, don't try always to incorporate the defect in your cut. Don't try to say, okay, I'll cut such a way that the defect is taken care. No. Cut as is required and you build up the defect with bone or whatever and then use a rod there. So be prepared to use augments and rod in these patients. But again, no release is required, as you can see. Then you have passively not correctable cases. There are two types. One, which have huge osteophytes. They are intimidating initially, but as soon as you remove osteophytes, everything becomes simple. They get balanced automatically. You don't need balancing. And if it is extra-articular deformity, as I showed in the last patient, you try to make up those deformities in the cut. For example, if femur is very bowed, you will take a 7-degree femur valgus and you will produce a trapezoidal space and not a rectangular space. Sometimes it balances automatically. You're lucky, the deformity is not much, extra-articular deformity. But if it doesn't balance, those are the only cases which need playing with soft tissues, MCL, etc. You can do extensive MCL release. If I do that ever, extensive MCL release, I always refix it after correction with an anchor. I don't want to leave my MCL hanging in the air and let the God decide where it is going to get fixed. I will fix it myself with an anchor so that I am sure that the length is maintained. You can do reduction osteotomy. Again, it is a bony procedure. You are very comfortable with doing it. You can do epicondylar osteotomy. Never, never, never would I do a pie crusting of MCL. Because MCL is a very sacrosanct ligament and you are not used to doing it. You do it once in a year. You just overdo a little and you are playing with it somehow and it cracks. Once it cracks, that knee is gone. So MCL is not to be touched, particularly pie crusting. It's a discarded procedure, but maybe in the hands of people who do it every day. Otherwise, I would suggest you keep away from that. I think with that, I thank everybody and thank the organizer for calling me here. And I hope the talk made some sense. Thank you.
Thank you, Dr. Maheshwari. Question for you. We'll take some few questions at this point probably. Any questions for Dr. Maheshwari? If not, what is your indication for a medial, in your sequence of releases, for a medial epicondylar osteotomy?
So when I've done everything, so medial reduction osteotomy is the next. So first of all, osteophyte removal, then posteromedial osteophyte removal, then reduction osteotomy. I've done most of the bony procedures. Spite of that, if I have a varus knee, then if it is minor, I would do a medial release of the MCL. But if it is too much, I do epicondylar osteotomy. So maybe for 1 or 2 degree, I will do MCL release, maybe halfway down. But if it is too much, then I do epicondylar osteotomy and don't go all the way down for MCL release. I don't do.
In a normal varus knee, which like a simple varus knee, what are your indications for putting up a rod when actually you are required in a varus knee?
Rod.
Rod.
Well, so two things, constraint and rods, are dependent on what do you want to achieve. Rod I use when my bony stability of the component is not going to be good. Varus knee, valgus knee, whatever. If my component has a good seating space, the bone quality is good, no rod. For example, in a standard varus knee, very osteoporotic bone, obese patient, I use the rod. Though they are well said, it's a very normal bone, but I don't trust that bone and I don't want my component to sink tomorrow. So in obese people, in osteoporotic people, even in a usual varus knee or usual TKR, you can say, very often I have a low threshold for using a stem.
When the defect is large.
If the defect is large, I always use a stem.
Thank you.
Hello. Hello. Yeah. Sorry. Sir, what is your stop point? Up to what level will you do a balancing if you have a very lax lateral ligament? Sometimes when you do this medial soft tissue release, you may get some amount of correction, but there is still a lax lateral collateral ligament allowing some amount of opening laterally when you do your varus valgus stress maneuver in flexion. So do you go all the way till you get balance, or you accept certain amount of lateral ligamentous laxity?
I don't accept. So I'll tell you why. Because if you have a lateral ligament laxity, which patient was walking on it, it is not a dependable ligament.
Yeah.
Then if you leave even 1 or 2 degree of varus alignment, which you cannot sometimes control if you're not doing navigation, etc., then that will fail.
No,
so I'm very cynical about not leaving a lax lateral ligament and do whatever I can do to get my balance very proper.
Because that
Or I ensure that my overall alignment of the limb is not varus at all.
Thank you. Excellent presentation. Just working all insights into a very common deformity. This we know that like in all replacement patient, we have to manage the bone first, removing all the osteophytes, removing all the bones. But doing this epicondylar osteotomy, me, time and the osteotomy rather than doing the medial collateral ligament release.
Well, I must tell you, there was a great hesitation even in my mind because this is something we don't do usually. But believing in my concept that touch the bone because bone healing is predictable. So I can make the cut where I want, I can fix it where I want, and in all probability this will in 4 to 6 weeks time. I do not know that about the ligament. So I have switched from playing too much with the MCL to doing a medial epicondylar osteotomy. It's done maybe, I would say, 2 or 3 times in a year. That kind of extreme imbalance is not common.
Just there was only one case whereby you said that you always.
Can't hear.
There's one case whereby you said that you nearly always do a medial collateral ligament release, which is the one that looks the most simple. The last one you showed.
Yeah.
You said that's the one you always worry that you will have to do a release. For me, when I see those cases, you can see that the literature is changing now a little bit. But for me, if I had a case like that, I tend to change my tibial orientation, putting that case in a little bit more kinematic alignment, and therefore I don't have to do a release on that patient.
Couldn't really hear you.
I think.
Could you get what? I could not hear you. There's some sound issue here.
Can you hear me now?
Yeah, that's better.
So, The last case you presented was the patient who has some varus alignment in his tibia. He doesn't have correction. He doesn't have a lot of osteophytes. And that's the case you see as your most challenging case.
Yeah.
And in my opinion, in that case, if you put that case in a more mechanical alignment and you correct that tibia to a mechanical alignment in that tibia, that is when you're going to have to do the release. If you put that knee in a more kinematic alignment and you go to a bit more varus in the tibia, you are unlikely to need a release in that case.
Yeah, you're right. So lately, or maybe in the last 2-3 years, I don't aim a 0-degree axis in those patients, and that's where the need for release has gone down. You're right. So you don't aim at 0-degree, we aim at 2-degree, which is okay because the ligaments are okay.
Thank you, Dr. Maheshwari, for a wonderful talk. Now I'll invite Dr. Anil, who will be speaking on valgus knee, how to come out of maze.
Thank you, Dr. Prasad, and the entire team for having me here. I think it's the 4th or 5th time I'm coming to CAWNPORE for this arthroplasty course, and I enjoy it every time. My topic for today is the approach to the challenge in a valgus knee, or the axis, and also assess how much of the deformity is correctable. Now, if you look at the assessments, we need to draw the angles, we need to know what correction we are aiming up intraoperatively. Now, all of us are aware, as we already seen, that the valgus deformity accounts for about 10 to 15% of the total knee arthroplasties. And it's a very rare situation, and you need to be aware right from the outset as we begin handling the problem, what are the structures that are affected. It is the IT band, the PCL, the LCL, and the popliteus. Now, step 1, where do we make the distal femoral cut? Now, we make it at 3 degrees of valgus as opposed to the standard 5 to 7 in order to achieve that valgus correction and in order to achieve a stable alignment. Number 2, if you look at the distal femoral resection itself, there will be minimal or hardly any resection from the lateral condyle. And also from the tibia, as we go ahead to establish your extension gap, we realize that very little bone is removed from these valgus knees. And that is what will also guide you to the direction in which we have aligned these knees so that we go with the bone cuts first. Once we establish that, we classically put in a spacer. We realize that it does go in on the medial side but does not enter on the lateral side. And that is when you got to start doing your soft tissue release, being aware of what are the structures that are causing this tightness. Go ahead with the soft tissue release and thereby release the IT band and also the posterior capsule. Now, what we need to be aware of at this point is the proximity of the common peroneal nerve to the posterolateral corner. And we release at the level of the tibial cut to be on the safer side, because it can be as close as 1.8 or even 2 centimeters to the level. So the closer you stay to the tibia, the safer you are. Now, the releases, it can be done with a needle, it can be done very controlled with 11 or a 15 blade, but again, be aware of the depth of penetration and be aware and be always judicious that we use 2 laminar spreaders, because that will give you the feeling of the release that is adequate, that can be balanced on the medial and the lateral side. Once that is done, we can keep checking back with the spacer block so that we get an adequate gap before we proceed to more significant release. Now, the sequence, like we said, the IT band, the PCL and the PLC, the posterior capsule, and almost never we touch the LCL. I've just mentioned here for sake of completion. The next step that we need to do is the femoral sizing, and more importantly, the rotation, especially in these valgus knees. That is very crucial because the patellar tracking and the lateral condyle hyperplasia can play an important role in erring on the side of internal rotation. This is a typical knee that was done, staged. We did the left first, then we went on to do the right because the patient came back much later. Again, following the principles, minimal resection, lateral release, get it back with the balancing, pay attention to rotation, and then get back the tracking as well as the back gaps that are balanced. Now, what happens to the little more severe types? The right knee, valgus knee, most symptomatic. Again, like we said, we need to go through the routine set of x-rays for a pre-op evaluation. Be aware that the femur and the tibia are affected. Majority of the problem is in the femur, and the cuts would be minimal. Again, follow the principles of soft tissue balancing. You land up with using a thin poly. You do not land up with using an oversized poly, and you get a good balance with a good postoperative range of movement. Now, the most severe types of valgus that you have, wherein the lady comes to you with a good range of movement, classically when you flex, the deformity disappears, reveals that the entire deformity is in the femur. Now, this is when you would like to do a couple of x-rays, which leads to a lot of the standing x-rays, as well as what we call the stress views, which can give you a lot of idea of the soft tissue and also the correctability of the deformity. Now, if you look at the difference between the varus and the valgus, there is a lot of difference. And that gives you the idea of the soft tissue sleeve. And that also gives you an idea of how much of soft tissue release has to be done intraoperatively. Now, this is where in the valgus knee, you've got to be a little wary because the medial structures are elongated. And this is the post-op x-ray that we've done, or the post-op range of movement that this lady is having after this procedure, where we used LCCK type of constraint because of that medial laxity after having balanced the knee. And this is done with medial imbrication as well. And this is the follow-up at 1 year, where she has a good range of movement, a balanced knee, and also we got a good joint line restoration as well. Now, some of the more complex situations that we've seen much earlier, this is an injury who presented 20 years back in a 48-year-old male, deformity, pain, crepitations. Remember, this deformity was partly correctable, but if you look at the x-ray, this was not an uncommon finding in our situation. Neglected trauma, and if we went to a CT scan just to assess what the exact situation was, we can see that the large condylar aspect is probably partly united, and also there's a large fragment that is sitting outside. So we had a sequelae of a deformity on both sides, and this essentially was managed again with the soft tissue release. This was done significantly about 10 to 12 years back. We noticed the deformity, went in, did a fixation of that condyle and to achieve the balancing, and put in a component which was stable. The only issue was whether we should have probably added a stem. Now, fortunately, he's done well at 12-year follow-up. Again, a plate to augment the fixation and a stem on the femoral side would have been an ideal combination. He's come back at 12 years with a good range of follow-up. However, if you look at the x-rays carefully, going back, you can see that the patella that we've replaced is fragmented, and in spite of that, he's having a good range of movement. Now, the only critique that we had to ourselves, this was done 12 years back, whether we should have added a plate or whether we should have added a stem on the femoral side. And that is the only thing, although he's doing well with a good range of movement. Now, what we do with the more severe types of valgus, you have a fixed valgus, you have a fixed flexion deformity, and a relatively physiologically younger patient. And that is the indication for a lateral epicondylar osteotomy. And if you look at it, that is better for achieving the soft tissue balancing in this particular situation. This was a 63-year-old lady, a retired school teacher, who had come to us with a significant valgus of the knee. However, when we looked at it, one of the parameters to assess is also the hip and the spine. She had a bilateral hip that was neglected. So obviously, as in the sequence of events, we did a correction of the hip first. We took a CT scan to assess the bone stock, and we went ahead with a shortening osteotomy. Obviously, poor bone stock, we had to do a cemented fixation on the hip side. Post-op, she had, because she was in bed for a long time, prior to that she had a gluteal sore, and we had to wait for a fair duration of time before we did the knee, and there we did a classical lateral epicondylar osteotomy and achieved this balance. So this is an approach to a complex problem where we do a lateral epicondylar osteotomy and allow the soft, fix it back to the origin to get that soft tissue balance. Another important marker or another important indicator would be the medial joint space in a preoperative x-ray. If it opens to about 20 millimeters, you're definitely handling medial structure incompetence, and that is the level we probably even think of MCL advancement, an imbrication, or even with regards to a constraint also. So femoral sizing is important, femoral sizing and rotation are important, and more importantly, especially in these significant deformities, assess the mediolateral laxity. That could play a significant indicator in the level of release that you have to do and also in the level of constraint that can be done. This was a lateral view, the defect. Whether a CT was required, no. A preoperative clinical assessment was done. Again, soft tissue balancing was done and a minimal constraint implant put to get in the alignment. So the message, valgus is rare, and remember the sequence would be a full extension release with the IT band, PCL and posterior capsule. Persistent tightness, you need to do a graded release, and remember the fixed valgus, a lateral epicondylar osteotomy is indicated. And that would also include a careful closing of the medial structure with imbrication as well. Thank you for your attention.
Do we have any? Do you always keep the similar amount of femoral component rotation, or do you change as per the degree of valgus you have in the knee?
The external rotation?
External rotation of the femoral component.
Yes. So that's a good question. Actually speaking, because when we do the femoral rotation, we have the 3-degree external rotation and the 5-degree external rotation on table. So right from the beginning, we mark the epicondylar axis and we keep checking the rotation, and before we make the cut, we put in the spacer block to assess whether rotation is adequate. So if it is not adequate, there are significant valgus knees where we have rotated to 5 degrees simply because the lateral condyle, the paddle doesn't sit on the lateral condyle. So there it is a must that we have to external rotate, and that's very valid before we make the cut, because once we make the cut we are too late.
Thank you.
Yeah, one more question. This was an excellent presentation for a very difficult deformities in the knee replacement surgeries. So in most of the cases, like the recommendations are that we put the valgus cut in the femoral side to around 3 degrees or less than 5 degrees. So whenever we do that, there is no bone resected from the lateral side.
Yes.
Right, and in most of the cases, we have to cut extra bone and then put the augments there. I didn't find any augment in your case.
No, in fact, the medial side, the lateral side, we hardly touch. So that is a good indication that you've got your valgus correct. Because if there's a significant valgus deformity and you put your alignment rod and cut it 3 degrees, more often than not, you will just graze the top of the lateral condyle, or you will not even touch the lateral condyle. In that instance, we put a lot of drill holes, but never have we needed the augments on the lateral side, simply because we take a minimal resection and we grade the resection before we cut it. Augments are almost never indicated or never required, I would say, in a valgus knee. The only thing that would be pointing you in the right direction is that we make a minimal cut, or we'll be just grazing the lateral condyle.
In that case,
because if you need an augment, that means you've gone probably a little too high in your distal femoral resection. We'd always undercut before we take it, because that will alter your joint line as well.
That will lead to more valgus cut on the distal femoral side.
Correct. So that means you're taken, either the valgus is wrong, or we have done the distal resection a little more than what is required.
Yeah. One more.
So that is a good indicator. If you have not touched your lateral condyle and if you have just grazed it, that means your valgus angle that you have established is correct and your level of distal resection is also correct.
So whenever you have to do pie crusting of the lateral collateral ligament and the popliteus, will you prefer doing epicondylar osteotomy or pie crusting of the ligaments and then using the semi-constant process?
All are releases with the IT band. The popliteus and the LCL almost never. LCL almost never.
Yeah.
Never. I think that's a message that should go out. I think LCL we never touch.
Yeah.
And that's why I put it as a last line. I probably put it, one size font down. And the popliteus very rarely is required, even in the most severe, and that is where you do your lateral epicondylar osteotomy, allow it to slide to the position where we get it. That's why it's a long sliver of bone that we take for the lateral epicondylar osteotomy. Allow it to slide and fix it. That is the situation.
Thank you very much. Very nice.
One last question. So one of the X-ray you shown to us that medial opening is almost more than 20 millimeter.
Yes.
And you said any constraint. So which implant you will be more comfortable? It's the semi-constrained or fully constrained?
No, semi-constrained. I always go up just one level. So if you're using a PS, go to the next level, varus valgus constraint, either with the poly change alone or a TC3 or an LCCK type of implant. That should do.
So you will be more happy with the semi-constrained one?
Yes. Yes.
But what we are doing, it's fully constrained we are using in such type of severe cases.
Fully constrained meaning a hinge?
Yeah, hinge.
Okay. But that I think is not probably indicated in the primary setting. I would rather say be careful in choosing your level of constraint, because these are primary needs. Because once you use a rotating hinge or once you use the highest in the ladder of constraint, then for the next option, we do not have anything. So if you carefully balance, I think we can still go ahead with one level of constraint that is lesser, which would be an LCCK bar TC3. I don't want to use company names, whatever is the...
Because maybe I can answer. I think over the years I've found to get that right balance, that your stressed MCL will still save you, is a very tricky thing.
So
Once there is so much once there is so much valgus and MCL is more or less dysfunctional, then to depend on that MCL means you are playing with fire.
Yes.
So my threshold for using a hinge, particularly somebody more than 70 and somebody obese, is very low. I use a hinge.
Very well
because
taken.
I can't trust that MCL.
Very well taken, sir. But we are talking about the younger, physiologically active. I'm talking about the younger hinge in a physiologically active 50, 60. I think this might be an overkill.
So in continuation to the same discussion and the question that I asked Dr. Maheshwari, what is your threshold for when you would accept some amount of laxity after you finish the procedure? And medial, obviously in your case is lateral, in his case is medial. You've done all the cuts and you find now after whatever you've done, you're still on doing a check post trialing that there is opening medially, say 2-3 millimeters. So what's your threshold to say, okay, this is fine, and what do you do if you don't accept that?
Yeah, so if it is about 2 to 3 millimeters, just as we accept for a varus knee, I would leave it at that and also imbricate the medial side. I would really pull it up on the medial side and imbricate it. In fact, there's been described of doing a medial epicondylar type osteotomy to proximal migraines feather cup. But if it's opening more than that, then I would go for the next level. That is an LCCK bar TC.
Thank you, Dr. Anil. Now we'll invite Dr. James for his talk, and he would be speaking on bone defect management.
Just a brief point on your thing about the imbrication of the ligament. So I think when you imbricate the ligament, you really can't control what's going to happen because it may undo you. Sometimes in those cases, I will use the hamstring and I'll reconstruct the ligament on the hamstring side with a hamstring because that gives me a far more definitive fixation than an imbrication. So instead of, or even the osteotomy, but for me it's a hamstring because it's quick. I can drill it in. I do a lot of soft tissue knees. It's the same procedure. It takes 5 minutes and it gives me a lot of stability and I don't brace them afterwards and they can mobilize immediately. Okay, so thank you very much for the invitation. Can we click up my slides? So I've been asked to speak with you on bone loss management. These are my disclosures. So, as we all know, revision in failure in revision TKA, you can often up to have about 18 to 20% of these cases will fail after 5 to 10 years. So even if you do a good revision knee replacement and you have maybe just a simple cemented stem or simple augments, you may find that these knees will come back. So there's a substantial number of these knees end up with failures, fractures at an early stage. So sometimes we need something else to be able to do this. You need to know when you're managing bone loss that you need to think of a lot of things. You need to decide whether it's a small or a large defect, whether it's contained or uncontained, what the quality of the bone is, what your patient factors are, what your ages are, what your activity levels, and what has been used previously. Was it cement? Was it bone? Was it stems? What have you taken out? You need to understand something about classification of bone defects as to where they are. It's important to understand you cannot classify a bone defect or understand that pre-operatively. When I do these cases, I only make an assessment of the bone defects when I've taken all the implants out and I've done all the cleaning up, and it's at that point then I assess what my bone defects are. When I talk about management of bone defects, a lot of people sort of understand this as managing sleeves versus cones. And some people say, well, I'm definitely a sleeve user and I'm definitely a cone user. Well, for me, it's a bit like talking about Batman and Superman. They're both good guys. One has a slightly dark side, one is perfect. But to be honest with you, both of these things work really well. There's not a major difference in them for me. There are slight differences, and I'll try to explain that in a while. When you're going to do these fixations, you need to understand zonal fixation. Ridian Morgan-Jones and Heiko Greichen have written extensively on zonal fixation. So we talk about zonal fixation in zone 1, which is really epiphyseal fixation, zone 2, which is metaphyseal fixation, and zone 3, which is diaphyseal fixation. And in these revision cases, you should be looking to fix in 2 of these 3 zones. If you only get fixation in one zone, you will fail. So you're looking to get fixation in zone 2 and zone 3, or zone 1 and zone 3, but you should be looking to get fixation in 2 of the 3 zones. Always remember, it's worse than you think. If you look at the first x-ray, you say, that'll be fine, that'll be okay, I'll get away with this. And this is what you end up taking out of the patient. And then if you don't have the proper equipment with you when you start these cases, you're going to end up in trouble. So if you don't plan properly, you're going to regret what you did. So here you go, revision case with sleeves and stems and fix back up. So what's the difference between sleeves and cones? Why would I use one versus the other? If you use a sleeve in a practice, you can use them even in the presence of big bone defects. It gives you very, very solid fixation. You can position the sleeves where the defect is. The sleeve position and the implant position occur independently of each other. You can treat the defect and you can fix the implant all in one step. And you can use completely cementless fixation in these cases. So by going cementless with this fixation, you're not relying on the interaction between cement and bone quality and inadequate cement fixation. So here you can see sleeves with large defects. They're not completely covered. You can actually see the tibial component is sitting up out of the tray. So in this case here, you've got fixation in the diaphysis, fixation in the metaphysis, and you have no fixation in zone 1. But you can also use the sleeve to elevate the joint line so that you can reduce the size of your poly and reduce the stress on that component. The other advantages of sleeves is that you can set the rotation of the sleeve independently. So you can set that rotation to correct the rotation of the component as you put it in. Similarly, you can do the same thing on the tibial side. So one of the advantages of sleeves in using them in daily routine is you can really use them in complex cases. Here you can see sleeves on the tibial side, sleeves on the femoral side. One of the advantages of sleeves on the femur is that you can actually use the femoral sleeve to close down your flexion gap. So you can flex the sleeve a little bit, and that helps to close down your flexion gap, and it helps you to stop that mid-flexion instability, which you will often see in revision knees. When people do revision knees, they say, it's a revision, what do you expect? But to be honest with you, I expect that my patients have a revision knee and they function as well as a primary knee. You can also use a sleeve. One of the things you can have to worry about with sleeves is if you've got abnormal geometry, if you've got defects further down the canal, or if you can't get optimal placement because you've got a risk of mechanical fracture. So you've got to be careful of sleeves in patients who have severe deformities in the proximal tibia or in the proximal third of the tibia, because then you can have a problem. And this is what can happen to you if you're not careful, particularly if you don't recognize the intraoperative fracture. And I noticed earlier people were asking whether you put a cable on these cases. I don't always use cables, but if I think the crack is unstable and the sleeve is not stable, I will put a cable on, take the sleeve out, and then refix it before I finish. Okay, so if you've got cementless fixation in zone 2 with a sleeve, it gives you very good clinical and external results and midterm results. So if you've got these, do you really need to use a stem if you've got a sleeve? Because the sleeve gives very good fixation, so maybe we should get away with this. Can we use a stem? What type of bone defects do we have? Are the tibia and the femur alike? And what's about the influence of constraint if we have too much constraint? So here's a nice paper that came from Heiko Greichen looking at 93 patients with 118 sleeves. And these were patients that were done with sleeves without stems. And you can see that they can get very good outcome in these patients with really one episode of tibial loosening. So for me, I use a sleeve if I get good, without a stem, if I get good fixation in zone 1, if I have a good bone quality in zone 2, therefore I don't need to go zone 3. Okay, so here you go. Here's a patient with severe deformity, fracture. There's a sleeve in the patient, and there's a sleeve with a stem in this one. If the patient has got an uncontained defect and if they're problematic because of force distribution, well then maybe I will have to use a stem to go all the way down. In terms of augments on the femur, if I've got a sleeve on the femur and I don't have a stem, but I have to use large augments, if I'm going for more than 4 augments, 4 millimeters of an augment, well then I am considering putting a stem in the femur. On the tibial side, it's easier to figure out, but on the femoral side, when I'm using more than 4 millimeters, I want to put a sleeve and a stem because I really have a lot more force being transmitted because the length of that lever arm into the sleeve and the stem is higher. Okay? The bone quality is really important in these cases. If you're worried about the bone quality, well then you should definitely use a stem with the sleeve. What about constraint? Well then you've got to use more. If you've got more constraint in the case, well then I think you should be looking for more fixation, because if you've got more constraint, you're going to increase the force that's transmitted through to the implants, and therefore you should really be looking to use a stem with a sleeve if you've got constraint. I will only use a sleeve without a stem if I've got a VVC or a primary poly in those cases. But as soon as I've started to use more constraint, I'm going to put a stem in. Okay? You've got to remember that the sleeve is mobile bearing, and therefore it can reduce some of the stress, but it does not reduce all of the stress. So again, here's more papers looking at stems and sleeves. Heiko Greichen's paper, where he has got a lot of these cases with sleeves without a stem, very good fixation, and I will often do these cases. So what's the advantage of a cone? So cones have been around for a number of years. They come in lots of different shapes and sizes. When cones came out first, they were very, very difficult to use. You had to get a burr, you had to shape the tibia to get it exactly the shape you wanted, and the surgeons found them difficult to implant. Over time, things have improved, the instrumentation around them has improved, and now you can put in a cone much better than you used to be able to do in the past, and you're able to cement these in position to exactly where they want to go. The difference between the cones and the sleeves for me is, with the cones you could do a lot more asymmetric shapes, a lot more different sizes and shapes. The sleeves tend to be one size. With the more modern sleeves, you now have a lot more variation in sizes. You have a lot more bigger sizes with the Attune revision system. Whereas with the cones, sometimes you have to get these specifically made, and they don't always come in the box. So you need to be aware that if you have to use a cone sometimes, you may need to get one that specifically fits the component you want, and it may not be the one that you have in the box. When you prepare a cone, you've got to remember that you will have defects around the cone, and you may have to fill this with bone graft or bone wax to try and stop cement falling down between the cone and the bone. Because once you start to get cement getting into this area when you prepare them, the cement will stop your sleeve or your cone getting fixed into your tibia. What about the outcomes of cones? Here's a patient who had a cone that was put in. You can see that the stems with cones work really well. If you use them for a period of time, you use a really short stem. You don't always have to go to a long stem. You can use a short cemented stem in cones, and they work very well. This is a case that I had of mine, which had a cone put in. You can see I've removed the stem, but once I've removed the stem, the cone is still really, really solid. I then just burred up the cement, created the shape that I wanted, and then put the new stem back down into that. So I was able to put a stemmed component back into a cone when it was fixed. The difference between cones and stems and sleeves is that the cone really only is a bone filler. It doesn't help you to set your joint line, it doesn't help you to set your rotation, and you have to do all that independently of the cone. So here's another case of mine. This is a patient who had an infected knee replacement, had a first stage revision done. Unfortunately, after his first stage revision, he fell and broke his hip. He had metalwork in his femur from a previous old femur fracture. His first stage revision remained infected, so we had to take him back for a repeat first stage. So you can see now we have a huge defect in the femur, huge defect in the tibia. You'll see this case here. Here's the sleeve in case. You can see I've got a lot of bone uncoverage. I've done a tibial tuberosity osteotomy. I've got stability and flexion. I can lift the knee and it's really, really solid. The next one. So this is the intraoperative picture showing the tibial tuberosity osteotomy to allow access. You can see that I've got a lot of uncovering on the sleeve on the medial side. I've got the patella resurfaced. And you can see this patient, I'm going to show you his post-op x-rays. You can see here I've used a sleeve without a stem because I got metal work up. I've put a cable in to protect against a stress riser as best as I can. I didn't bridge with another plate. You can see on the tibial side the tuberosity osteotomy is healing, is in good position. I've got a lot of areas of the sleeve with no contact. In this case, I'm probably down to about 40% of contact with the sleeve. But I've used a fully porous coated sleeve. The sleeves now come in partially coated and fully coated. And in this case, I've used a fully porous coated sleeve, which allows me to get fixation way down in the diaphyseal level. So I'm able to get away with a little bit more in this case than you normally would. You can see he's got a defect in the tibia as well, so I have a long stem down below and I've got diaphyseal fixation. So you can see I'm trying to get fixation in zone 2 and zone 3. So this is this patient at about 4 weeks after surgery. He's straight leg raising, his wound is fully healed. We had to keep him in because he was a patient who had a lot of social problems. This is him fully weight bearing on his knee at 4 weeks with a sleeve with 40% contact with the tibial tuberosity osteotomy. So I had this patient weight bearing from day one. He's still a bit slow, he's not going particularly quickly, but he's fully weight bearing without crutches at 4 weeks. So here's another case. This is a sleeve with impaction bone grafting. Here's a case of a periprosthetic fracture. This is a next-gen knee which has a history of loosening on people. And you can see there's a large periprosthetic fracture around the distal femur. I've used a sleeve, I've used a pegged stem. Somebody asked earlier about whether how do you reduce the incidence of pain in the bone if you've got a stem. So I'm using stems with pegs to try and reduce the stress that's being impacted down onto the bone. So rather than using solid stems, This case is very like the case that was presented earlier of the patient who had the stress riser in the tibia, and you can see I've used unicortical fixation to get rotational control and realignment of my fracture before I plate this, before I put my implants in. And again, you can see there's a sleeve inside. I don't have full contact with my tibia all around. I have a stem with good distal fixation, and I have a unicortical plate to align me. Here's another question. This is a case which came to my clinic last week. So I don't have the post-operative x-ray to show you, but I thought it was a good case to show. And I wanted to ask people's opinion, having just said what I've said. Who would put a sleeve in this? Who would put a cone in this? Can I get a show of answers? Can a show of hands? Who'd put a sleeve in this? And who'd put a cone? 2. So I'm going to explain my thinking. I haven't done the operation yet, but you can see that this is a major deformity on the metaphyseal side. You don't have a lot of access to the diaphysis in this case. So putting a stem down here to get a sleeve fixation with a stem to get down to the diaphysis and the lateral view is going to be a problem. So your stem is going to be way back. You may have to use an offset stem to get all the way back. If you look at the anterior view, again you have a deformity. So for me in this case, I'm going to use a cone in this case, because I'm going to use a cone with a short cemented stem so that I can get that fixation as close as I can to the joint line. I don't think a sleeve, I would worry about a sleeve in this case because it might crack, or you might not get enough fixation in zone 1 and zone 2, and therefore you'll have a problem. And the other problem with a sleeve, sometimes in cases like this, is if you use sometimes with the sleeve, you need to put a stem on it initially to ream it in the direction you want. So when you put the sleeve down, it can sometimes tend, if you put it down without a stem on to guide you, it can sometimes tip you into varus or valgus. So I will always put a trial stem on first to ream, and then I take it off when I put my definitive implant in. So what about the outcomes of sleeves versus stems? You can see sleeves give very, very good outcomes. A loosening rate of 0.7% in sleeves. You'll get about 3% of cases whereby you can get an intraoperative fracture if you're not careful. In the early phases of which I did these, I had 1 or 2. I've not had a fracture now for many years because I've become much more comfortable and understanding of how it works. Typically the fracture will occur in your first 1 or 2 cases when you don't understand what you're doing. In terms of cones, again, you've got very, very good outcomes from cones. You've got very good long-term outcome. Slightly increased evidence that there's a bit of loosening in the cone more than the sleeve at about 1.3%. But I don't think it's hugely important. So it's good to see that there's no difference between Superman and Batman, really. It's a question of who you want to be. But it's very important that you know who Superman is in this part of the world. Thank you very much.
So when you are hitting the sleeve, like preparing the canal for sleeve, you have size 1, size 2, size 3. How do you stop where? Because you're worried you may just bang the next size and the
for me, it's, if you see in the case that I showed you their video, I'm testing it every time I put the sleeve in. I put the sleeve in and I'm testing for my stability. I'm looking to get stability immediately. I will go for the smallest sleeve I can get in. And I want to get absolute stability and rotation, and that I can lift the limb and the sleeve isn't going to move on me. And so it's you test each sleeve. You don't keep going. You test on each one as you go along.
All right. Thank you.
So just in continuation of the same, what criteria do you use to decide the length of your stem?
So the length
on both the sides, on the femoral side as well as the vestibular side.
So there's 2 things. Firstly, it depends on what my fixation is. Secondly, if you use a sleeve, I tend to stay away from the longer stems, because if I use a longer stem, I'm getting more and more diaphyseal fixation, particularly on the femoral side, and that tends to drive you more into extension. So I'm always looking to make sure that I avoid my femoral component going into extension, because that will create a problem for me when I'm trying to balance the knee. I'm trying to use a shorter sleeve if I can, in a shorter sleeve with a bigger diameter to get more fixation on the femoral side. On the tibial side, I always use a longer stem to start so that I align myself, and very frequently I don't use a stem at all on the tibial side. I've stopped. If I've got good fixation, I tend not to.
So what I take back is the shortest possible stem on the femoral side so that you can get some amount of flexion.
Correct.
And maybe no stem on the tibial side if you're using a well-fixed zone 2 fixation.
And really you need to make sure that you have, typically for me it's about 100 stem, you have 160 option. So there's a 60, I think it's a 60, 110 and 160. The most common one I would use would be 110, because with a 60 with a sleeve, sometimes you can't get any fixation, but I will always ream with the 110 so that it aligns me, because I know I'm getting in the diaphysis, and then I may take it off or go to something after that.
So you're not relying on the stem at all, unless and until there's no choice. That's what you're trying to say.
That's what I'm trying to do, yeah.
Okay, thank you.
So even in poor quality bone, you will just use a sleeve, or you will always use sleeve with the stem in a poor
so
quality
the bone quality is important. If I don't have, sometimes I will ream the sleeve to whereby I've got endosteal fixation. If you find that the cancellous bone is very poor, but if you get good fixation in the endosteal bone, I mightn't use a sleeve. No, I've got very bold.
The problem here is some of our femurs and tibias are very small, especially for the smaller ladies. Even the smallest sleeve, 31, and correspondingly, they tend to be just snugly fitting. And you're worried, a little worried, especially in the osteoporotic bone. So,
yeah. So I do. We have osteoporosis in Ireland, the same as you guys do.
But the smaller sizes, I'm sure, are not a common entity there.
We have small femurs and we have small ladies. I mean, I have ladies who are only this height in my clinic all the time.
So how do you handle the sleeve situation there? In the sense, because you're handling a narrow canal, you have a femoral size ultimately 1.5, if you're doing that, and then you need to handle the bone defect as well. So what is your choice in that situation?
I mean, it may be that the only sleeve I can get in is the smallest one, or sometimes you can only get a sleeve in with no stem. It depends. It's not common to have to do it, but it does depend. I certainly always consider whether I would have to use a cone or not, and sometimes your only option is a cone, like in that case I've shown you. My workhorse case that I use all the time is a sleeve. My workhorse for the vast majority of cases I do is a sleeve. The cone is something that I use then for more particular cases.
So I think we can conclude the session. I think take-home message from that is sleeves is used for a majority of the cases. I think cones are reserved for specific situations where we cannot get the sleeve in the direction of the canal.
Correct.
And that would be the indication for cone. Unfortunately, I think in this part of the world cones are not readily available. So we have problems with the availability of cones. But again, like we said, I think we should be clear about where sleeves are indicated and where cones are indicated. Right. Thank you, and we will close the session.
Next session will be on, whoa, it's interesting complications. So, I would like to call the panelists, because what we are going to do, I'll be talking about prevention of complications rather than handling the complications. So that will be one thing. And I could not, because I could not prepare the slides, but I have got leading questions to ask my panelists. And can I ask my panelists to be here? They are Dr. Harty again. Dr. Harty again. Dr. Maheshwari, I think the best person to know how to prevent a complication. Dr. Anil Oman. I'm sorry, I'm calling you on the dais again. Dr. Mudit Khanna. Mudit Khanna looked like a Bombay, stayed in Bombay, but one connection, he has passed out from KGMU, so he must be having a lot of friends. But he looks like a young star, reminded of my Beatle days. And Dr. Dhansekhar, if you can also come here. One more person. I think I want to have some leading opinions how to prevent infections. So let's see. ओए मैं भूल भी गया ना infection. So what are your take on prevention of infection? We'll start with that side and then we'll go to the higher center like Ireland, to Dr. Dhansekhar, and we can have so many things like operating room protocol, the point which I would like to the personnel or rather handle your OR persons, antibiotic protocol, operating room temperature. It has come into light that even making it very cool can also be detrimental. And any other your protocol for prevention of infection.
So actually, we start with preoperative factors. We basically classify the risk factors into correctable risk factors and not correctable risk factors. So correctable risk factors includes preoperative optimization of the patient, correcting anemia, controlling your blood sugar, nutrition, then rule out any source of infection. So these are the preoperative optimization we do. And second is operating room protocols. So that's very important. We limit the number of people entering the theater. We usually keep it closed. Then there is always a signboard saying surgery, orthoplasty surgery in progress. So nobody will think of coming in. All the implants and equipment necessary is always kept inside the theater beforehand so that they don't come and go. Every time you open the theater doors, there is a lot of air movement happening. And usually it's in a laminar flow theater, though it is debatable, but the vertical laminar flow theaters are useful. And so we can go on. I like to pass it to the
Yeah, so I mean, taking from here, I think in terms of antibiotics, I think it's standard as per guidelines. So we don't sort of it's just making sure that the first prophylactic antibiotic goes about half an hour before the incision. I don't use a tourniquet myself, but if somebody is using a tourniquet, then half an hour I think before inflation of the tourniquet. With antibiotics also, I think it's important. We just give 2 post-operative doses. We don't give antibiotics longer, which a lot of surgeons do. And I think again that comes down to, if there is an infection, we want to know. We don't want to hide an infection for longer and delay the time that we have to act in case we need to act. So yeah, in terms of operating room temperature, I will pass it on because I don't know if the evidence in favor or against the operating room temperature affecting the rates of infection.
I particularly have nothing to say about operating room temperature, except that as a surgeon I have to be comfortable. I should not be sweating, and if I am handling cement, it should work according to my timings. Apart from that, I don't think room temperature is important for me. The most important, any other I would like to add, particularly people who do not do it very regularly, the operation theatre discipline in a normal OT, even in an orthopedic OT, is very chaotic. So I think if you're doing joint replacement, be there from the word go. Stand there in the corner and you'll be surprised how your staff is doing all the wrong things. Particularly the company guys. They come, new fellow comes and he says, man, I've assisted in 100 patients. And you ask him to go and take a wash, you will know how many times he have washed in the case. So be very particular about the operation theatre staff before you drape the patient. They would have touched everywhere and you won't even know it. So it's a very good idea to stand there right through the operation if your discipline is not already established, if you're not doing it regularly.
Yeah, I think especially when you're not having your regular set of nurses and or your operating room assisting personnel, I think very, very important, like Dr. Maheshwari said, to be there from the outset, because there are a lot of things that they tend to pass off as normal, which should not be done. I think especially dipping into something and taking off, even draping the tables for that matter, they stand too close, they get unsterile, they even putting on the drapes, everything. I think these are things that we need to keep a close eye on. Just 2-3 other things that probably preoperatively, as Dhanashekhar said, diabetes especially, they're coming with a HbA1c of more than 9-10. I think we should all be, I have no hesitation to send them and bring them back later, because I think operating on somebody who's got a HbA1c above 10, bringing down the sugars rapidly and trying to take them up for an elective procedure, definitely not indicated. Rheumatoids and the group who are on DMRs, again, as we know, newer consensus is evolving that we don't have to stop anything except the biologicals. And one other thing is somebody who's had an intra-articular injection in the recent past. I think that we have to wait at least 8 to 12 weeks before taking up, because that is always a small focus of worry anytime, even if you're covered with this thing. And these are just 3 important points that I'd like to consider in addition to all the standard operating procedures.
For me, there's a few things that I probably do that might be a bit different. As the guys have said, you preoperatively prepare these patients, and that's a given and understanding. For me, I always, when I have the patient set up on the table, I always get alcohol gel and I put that on the knee, and I clean the knee with alcohol gel before I go scrub, because the alcohol gel will kill everything on the knee before I start, and then I paint. So it's a very simple thing. It takes literally 2 seconds. Just rub alcohol gel on it. It's evaporated off by the time I scrub and I go back. So I always set up my own patient. I always set up the table myself. I put alcohol gel on. That's evaporating. I wash. Then I paint. So the alcohol has killed anything in the site of the operation. The second thing is you need to be very efficient in how you do your operation. Surgeons who take an hour and a half to do a knee replacement, these will be the guys who get the infections. If you are efficient in how you do your surgery and you plan your surgery properly, you'll finish it in a reasonable time. The longer the wound is open, the higher the risk of infection. It is clearly shown that that's the problem. So if you're getting infections, you need to look at yourself and at your operative time. Thirdly, when I close the wounds, I don't use sutures and I don't use staples anymore. I use subcuticular barbed sutures, and I then also use glue. So by taking those out of my sutures, I don't have vicryl anymore in my wounds, and those patients which spit out the vicryl and then get a little small abscess in the area, that's gone from my practice. And by using glue, I have no staples to take out, so therefore my staple infection, my redness level goes down. And by using glue, my wound is sealed at the end of the case. The other thing that I will do is if I've got an obese patient or a heavier patient, I will tend to use some vacuum dressings to close them. I'll use the Pico-Vac or one of these low pressure vacuum dressings, because it helps to stop the ooze. Once you start and get the ooze, then it continues and then you have your problem. So I don't use these vac dressings in everybody. I use them in my revisions every case. I've been doing revisions and closing them with vac dressings for 13 years. I have not had an infected revision as soon as I've done this. And then I use these low pressure Pico dressings for obese patients to help me to reduce my infection rate or my concern with them.
Important. Can you hear me? No. Okay. Now you can hear me. That anyway. No, it's okay. So I'll ask. I think you people are more important. Another leading question. Your patient has in urine examination 10 to 15 pus cells, and the patient is asymptomatic. What will be your take? Maybe I'll say it's a hypothetical, so maybe 20 pus cells in the urine examination, but no symptoms, no, absolutely asymptomatic, and no history of UTI.
So for me, asymptomatic bacteriuria is not a contraindication to proceeding. If the patient has symptoms, well then fine, I consider it. But if they're asymptomatic, I do not treat it, and I just continue on. The vast majority of females over 60 will have asymptomatic bacteriuria, and therefore you'll be cancelling at least 50% of your operations if that's the case.
Recurrent UTI is a worry, but not asymptomatic bacteriuria, that for sure. Because as rightly said, majority of the females above 60, 70, if you do a routine urine, and that is not an indication for urine culture as well. I don't think that is also not,
I'm a little more timid. And you said not bacteriuria, you said pus cells.
Pus cells.
So 20 pus cells is different than bacteriuria. 20 pus cells for me is important. I would not take that chance. I will give them a course of antibiotic and wait. I will also do a culture, because infection is something, it can come from anywhere. If I ignore this, tomorrow infection happens, I don't think I can save myself.
So typically 15-20 pus cells, I would still sort of go ahead with the surgery. Normally, most of our patients, if they go through this through the medical screening, and if they have 15-20 pus cells, by the time they reach the physician for fitness, they all have their cultures done, and cultures negative, 15-20 pus cells, go ahead with surgery.
So we routinely do cultures. So urine routine showing pus cells. If the culture is negative, we don't bother. If the culture is positive, then we give a one shot of amikacin pre-op just before the surgery along with the pre-op antibiotic, because post-op they have urinary retention, you want to catheterize, then that can disseminate into bacteremia. So there's a single dose we give. And more worry is we operate VIP patient, they suddenly land up in septicemia, it's a problem. We operated previous ex-CM's father. Post-op you develop UTI and went into sepsis. So once in a while you get caught. So our protocol, if you have a positive culture, we give single dose. If it's multi-drug resistant, then we refer to urologist. We get a post-void residual urine, make sure your bladder function is okay. Urologist consultation is taken and make sure that the urinary infection is treated if it's multi-drug resistant. If it's a routine sensitive to most antibiotics, single dose pre-op amikacin.
Okay. Will it change if I say the same thing for a male or female? Because this 15 to 20 pus cells in a male and in a female, will it make any difference to you?
Only if the culture is positive. A male also, if you have a prostate enlargement.
In fact, you are doing everything is ideal according to book.
Correct.
So, but the other side, the couple of people, they will ignore. So, this is just a leading question. Will you ignore even if it is in a female or a male? Will it make any difference?
See, for me it is more medico-legal. Infection can happen in any case, but if there was a report pre-operatively saying that there was infection at that time, and if I ignore it, okay, I give antibiotics and nothing will happen, it will be 20. That's a different matter. But if I just ignore it and tomorrow infection happens due to any reason, I don't think anybody would leave me. Definitely not, the patient will not leave me ever.
I disagree. I think that the evidence is clear in the literature that having bacteriuria in a patient who is preoperatively asymptomatic, as long as they're asymptomatic bacteriuria, the evidence is quite clear that it doesn't increase the risk of infection of the joint and cancelling those cases. So I understand that you're being as careful and as cautious as you can be, but I think that if you're in any reasonable forum where you had experienced arthroplasty surgeons giving a report, they would say that you have no indication to stop doing that case.
Yeah, I think literature is pointing towards asymptomatic bacteriuria. That's not in favor of cancelling cases. However, asymptomatic bacteria in a patient who's had recurrent UTI in the past, history of gynecological for ladies, for history of recurrent UTI, again or had a healed UTI in the recent past, within the past 6 weeks or 8 weeks, then that warrants probable further investigation, why she's having a recurrent UTI, why he or she is having a recurrent UTI, and then we need to tackle the cause. But not for somebody who's routine screening, no history of UTI in the past, no history of any other problems in the past. That would be taken, and I think that's what James also is saying, that can be done safely. Again, your question with a male having 15 to 20 pus cells is a definite cause for concern, because there again you have to investigate further, again go into the history, and again delve into why somebody is having, if at all asymptomatic, symptomatic. I think that would be better for further investigation before taking up, because knee is an elective procedure.
So males with bacteriuria or asymptomatic bacteriuria, you think of people with prostate problems, post-radiation therapy. Some of these males can have retention, and they can have chronic retention that you're not aware of. So these males can present with, they can pass urine, but they have significant chronic retention, so they have overflow, incontinence and things like that. So a male certainly brings an alarm bell into my head, whereas asymptomatic females over 60, my automatic response is go ahead.
Okay. I think if I try to make a consensus, I just will say what I will do or what I practice. Any patient with such, I will simply go for more investigations. That's number one. In a male, the red flag is more, because in female, the evidence is there that they have this more of frequency, and actually when I say asymptomatic, it denotes that it is not going into the system. So your knee is separate from that. But still you have to be careful. It will be safe or prudent to go for further investigation to know that if there's no other problem, then we might go ahead. That's all.
So in my practice, I bilateral TKRs, they all get catheterization for 5 days in my practice, and unilateral don't. And the incidence of post-operative urine infection in my practice is about, where they were asymptomatic, nothing was there. is about, if I can give a guess, maybe 5 to 10%.
But
they come back with some urinary symptom, not knee symptoms. I'm worried then maybe it is irritation because of whatever.
Catheter.
And of course we catheterize for the reason of
catheter.
comfort, not so much for any other reason, because to handle a bilateral knee patient, a lady patient taking the pot all the time is very, very tedious. I don't want to catheterize them, but that's just for convenience.
But 5 days of catheterization? 5.
So the reason they're infected is because they're catheterized for 5 days. So bilateral knee replacements, I do one every week. I do them maybe 50, 60 a year, and I do not catheterize them. They all get up and mobilize on day one. They all go to the bathroom on day one. I never catheterize any patient. Even revisions, I don't catheterize revisions.
Okay, friends, I think just be cautious because it's a planned surgery. There's no harm in waiting for a couple of weeks or 1 week, a week, and let it be confirmed. Number two, about diabetes, that was again a very important point. What is your threshold for A1C? For A1C level, HbA1C level, where you will not operate and where you can take it for surgery. What is your threshold?
So 7 to 7.5 is the cutoff we keep.
7.5?
7.5, yeah.
Okay. Mudit, yours?
Yeah, I mean, less than 7.5 is acceptable, and when we're talking about HbA1c levels, we're obviously looking at, we are making sure that we're looking at the past 3 months as an average. So it's not about a situation where we've just, rapidly brought down the sugars and gone ahead with surgery.
So is it a range? Because there have been some people, I've just read an article that 7.7 to 8 is the range where you can go for surgery with caution. That's all.
So for me, it's 9. Once they're over 9, 9 is my number. Once they're 9 or over, I don't do them. If it's 8.5, it's...
So that becomes a grey area.
It's a grey area, but for me, once they get to 9, it's a no.
So 7.58 is acceptable, but beyond that, you have to be cautious. And beyond 9, and definitely never in 10. Don't operate. Wait for at least 3 weeks, 4 weeks when the diabetes is well controlled. Diabetes is known to be one of the biggest culprits for getting a chronic infection in your knees.
So one thing I like to point out, I'm quite interested in your way of practicing. So with me, I give 3 doses of antibiotics post-operatively. All my doctor patients, they give additional 5 days of antibiotic when they go home, without my permission.
Yeah.
They will give it because they think, doctor patient I'm talking about.
Yeah.
Same about this. If you operate on a diabetic 9 here and something happens, I think I can't convince anybody.
Yeah.
So that's the problem. Unless I have a law with me or literature with me,
I won't do a 9. It's not, that's not my cutoff. If it's 9, I won't do it. If it's 8.5, I will say, well, what was it last week? What was it the week before? What's the trend over a period of time? I only give 3 doses of antibiotics in primary joints. They do not get any more, no matter what. Yeah, well, in Ireland you cannot get a prescription unless you cannot turn up to somebody and get a drug from somebody just by going down to a friend down the corridor. They won't do that. They will all come back to me.
So what cement do you use for your primaries?
What?
Cement.
So cement, I use Palacos.
Plain or
with gentamicin.
So
I do a lot of cementless. The bulk of my knee replacements at this point in my life is cementless. So I don't use any cement.
Okay, fine.
So we don't use antibiotic cement, but in particular case where there is diabetes, very high diabetic, somebody who cannot control it below 8 or something, somewhere in the gray zone 8, I use antibiotic cement. High rheumatoid on steroids, high diabetics, prone for infection, I use antibiotic cement.
All my cemented cases have antibiotics, gentamicin loaded antibiotics. I don't use cement without antibiotics.
Okay. So the next, prevention of malalignment. I think we all have heard talk on varus and valgus knee. So I just want a couple of points from each panelist. What's their take to prevent any malalignment? How do you just a couple of points. It's a just take home message for everyone. What precautions you take.
So I think we have published 3 papers on this femoral and tibial osteotomies. So femur, we have long films for all our patients. We calculate the valgus correction angle for each patient. If it is 5, we use 5. If it is 7, we use 7. We go up to 7 or 8 or 9 also. So that is the femoral side. On the tibial side, again, we use that long film to see whether the tibia is straight or it's bowed. If it is bowed, then you need to shift the proximal reference point slightly laterally if it's in a lateral bowing. If it's medial bowing in the valgus, we shift it medially. So these are the few tricks we use intraoperatively. And tibia, I use an extramedullary jig with a drop rod to make sure that it is a perpendicular cut. On the femur, sometimes gross deformity, we use navigation. Otherwise, conventional, I use an individualized valgus correction angle to get a perfect cut matching the mechanical axis. Patella button, I always use a skyline view to see the patella tracking. If it is small tracking, then we need to do a lateral release. And most of the patella, the 3-peg patella, is self-aligning to the trochlear notch. So minimal malalignment is okay. But it has to be tracking at the end of the procedure.
So you replace patella always?
Most of the time, 85% of the time I resurface.
So do you think femoral rotation can help in patella tracking better?
Yes, femoral rotation always I match to the transepicondylar axis and then balance it to the proximal tibial cut for each case, and that helps in tracking better.
And what is the range of distal valgus cut for varus knee you have done based on your long x-rays?
So it has ranged from 3 to 10. That's the maximum I have.
So friend, that's important, 3 to 10 when you go for individualized. My high point has been 9 degrees of valgus cut. I was astounded what to do. 9 is little, but it was a lady with a coxa vara, and I thought my computer is telling me truth, so I did not go for 10, I made it 9, so let it be somewhere around that. So just an idea that range can vary from person to person, you must be prepared. So instead of going to 5, 6, but the other thing, the point is very important, the alignment and balancing, these two have to be matched, and if at all you have to choose one, I think balancing is the key. If it is balanced well, the little alignment issue can be taken care of. Again, your take.
So when you talk about the degree of varus or valgus, I actually don't look at a number anymore. I'm going to show you in my talk later how I think about this, because I think that the number reflects where you put your rod in, how you put your rod in, did you put your rod in varus, did you put your rod in valgus. So the number isn't actually really important, it's how you line up your cutting block. So I'll explain it in my talk later as to how I think about that, but when you put a number on it, I don't think that the number is actually as important as you think.
That's right.
I think with relation to the alignment and with relation to avoiding malalignment, I think keeping on checking before you make the cut is the most important thing intraoperatively. Pre-op planning is absolutely essential, but I think whatever methods you use intraoperatively, just a quick check before we execute the cut, I think that is absolutely mandatory, and I don't think any of us would deny that that is absolutely important. Before, especially the distal femur, proximal tibia, and more importantly, the femoral component rotation. I think because once you're done, the cut is done, it's done. So a quick check before that, whether you're having an asymmetric gap, whether you're having a symmetric gap, patellar tracking, everything. A quick check before the cut, the best option.
So I typically do most of my knees navigated, so alignment is taken care of there. I think rotation becomes important, and from the time I moved to using navigation, it's been increasingly more common for me to vary my rotation much more commonly than I used to. I would probably end up going from anywhere from 0 degrees of rotation to about 7 degrees of rotation, based on what the balancing is showing on the screen. But I think it's extremely important. I mean, transepicondylar axis is a good measure. In my experience, extremely difficult to reproduce. So you can draw the transepicondylar axis once, measure your rotation of it, draw it again. There's a high probability that it may be different. So I think more and more moved on to, getting the flexion gap symmetrical to the tibial cut. it gives a fair amount of idea whether using navigation or not using navigation. And I think it's important that that as you put your spacer in with inflection, and as you try and slowly pull it out, you will get to know which side is tighter and which side is not. So there are times when you may have to use 0 degrees, there are times when you may have to go up to 7 degrees. 3 degrees should be your default. I'm not disagreeing to that, but if you find that while using 3 degrees the gap is significantly asymmetrical, sort of re-evaluate and see what rotation would be best.
I would say to you that 3 degrees is even too conservative. The vast majority of times now in those knees, if you have to put them in with a measured resection, I think if you look at some of the literature, you'll see that 5 degrees is probably it. 3 degrees is a very historical number that was given from the time of Insall and people like that, but we now realize that there's a huge variation in rotation in femurs. So for me, even when I don't do measured resection that much anymore, but if I have to do measured resection, it's nearly 5 degrees before I start.
Okay. So when we started using navigation, as you said earlier in 2004, the navigation suggested a very valgus cut. Then we depended on medial soft tissue release to correct the extra-articular deformity. So that was a problem initially we were facing. Now with the routine use of epicondylar sliding osteotomy or extra-articular osteotomy, we are able to restore the mechanical alignment better. So that's what we're not worried about the extent of osteotomy, increasing the valgus correction angle or the lateralizing the cut and then changing the cut drastically. Because now we are able to manage it better with extra-articular procedure, osteotomy procedures.
So, okay. So, frankly, the alignment is important, but I think of all the things which you have heard, I'll just put up 2 things. Number 1, the concept is important. Execution is by your hand. And anyway, you have a rod, you have a inchy tape, a scale. So you can always, before cutting, you can check what you're going to cut is right or not. You have a stylus, you can check the depth of the cut, you can check the alignment, you have got typical bony markers. So with a rod and with a scale, you can always see where you're going to cut, is it okay or not. If you have cutting tibia is easier because it's a straight bone and you are cutting at 90 degrees, and 90 degrees your brain always looks at this perpendicular, you can always appreciate. The only thing you have to stand at the right place and see what your jig is going to cut. And for flexion gap, if you have cut tibia well, that surface is a bony landmark to get a rectangular flexion gap rather than the epicondylar, because it's very difficult to palpate the epicondyles. The posterior condyles, sometimes they are eroded. So those 2 may not be a good access. White side line, definitely yes, because that gives some idea about patella tracking. But depending upon where patella is, you will have to vary it, and you can always rotate. Everything is in your hand. Before cutting, you can rotate the jig and see that you are cutting rectangular and you are not going very close to the epicondyles or the collateral ligament attachment, or not coming down and doing a notching of anterior cortex, femur cortex. So I think that should help. Only one point I would like to ask, any take about how to check and prevent mid-flexion instability. That instability is important, we all know. If you have taken care of everything, the instability is because of the soft tissue problems, not because of bone. So how to, the constraint levels we have, but what about the mid-flexion instability?
So I think it's important to delineate between flexion instability and mid-flexion instability. Yeah. Flexion instability is whereby you definitely have a problem at 90 degrees. Mid-flexion instability is whereby the patient will tell you they have a problem at 30 to 40 degrees. You'll hear them typically complain about it in coming downstairs, they feel a little unstable, they don't trust the knee. Flexion instability is definitely a pure surgeon not paying attention. Mid-flexion instability really for me is it's a balancing problem. It's because you haven't done your cuts properly to get the balancing correct. And it then also means that you may be driving your femoral component into a little bit of extension. So you can always make a knee balance at 90 degrees, you can always make it knee balance and extension, but if you have got too much extension in your femoral component, you will get mid-flexion instability. And the patients will come back saying, oh, well, it gets a little bit swollen, it gets a bit sore, and it's a difficult thing to pick up. It's very much a clinical diagnosis. It's a very careful examination, and sometimes you will not prove it's there. It's something that you have to be suspicious of. But for me, it's all about the tissue balance. If you do not get your tissue balance right, you have a high risk of getting mid-flexion instability.
I think the chief point is the tissue balancing, and I think keeping on checking the extension with the flexion gaps. When we're talking about non-navigated, I'm sure navigated you'll have the full range where you can get the tissue balance right through the range of movement. But I think if you're doing non-navigated, just keep checking the balancing, and more importantly, depends on the system we are using. If you're using an anterior referencing system, and especially with the amount of flexion deformities that we see, we can always titrate the flexion gap better, because posterior referencing system would not allow for that. And that is one thing that we need to bear in mind. So it's always better to be aware of the instrumentation we are using. I think in our situation where we commonly see a flexion deformity, an anterior referencing system is much better, because we tend to always pay attention to the extension gap first, get that extension gap out, and if you're not careful, you will not be able to balance the flexion gap without using an because that's where you can play with the sizes before we can make a final cut.
Any other point you want to take?
So there are three instances where mid-flexion instability can happen. First is when you are correcting a fixed flexion deformity, you do not do adequate posterior capsular release and then do proximalization of the femur. There is like more distal femur, so your extension gap is tight. Flexion gap becomes tight because of the contour of the implant and the patella being back on position. So when you're moving from 30 to 45, you feel that mid-flexion instability. That is number one. Number two, when you're doing excessive medial release. So in extension, your posterior capsule is tight, your knee is stable. In flexion, your implants give stability and patella is there, it gives stability. But in 30 degrees of flexion, where your MCL provides stability, there is some laxity. So then again, you proximalize the femur. These are three instances where it happens. So specifically, these three instances has to be avoided. So these three situations has to be looked on. So any collateral ligament release should be done only after you correct your posterior capsule contracture. If you have a FFD, you release all your posterior osteophytes, make sure an extension gap is corrected through posterior capsule release rather than doing bony resection. So that is number one. Avoid excessive medial release. So keep checking every step, as Anil said, every step you compare your medial lateral gap and flexion extension gap. Don't do any excessive medial release. It looks as though it is stable in extension, but in mid-flexion is unstable. These are two instances we always look for.
So I will just finish it up, but yes, again, the word of caution. Number one, don't do over-release without even thinking and applying your mind what you aim for. If it is tight on medial side, where exactly it is tight? What are the structures? You just don't go on removing all the soft tissue around the medial tibia, because that can also lead to mid-flexion instability. If it's tight in extension, we all know the posterior oblique fibers have to be released. Just go 1 centimeter back, that's okay. But apart from soft tissue, the handling of osteophytes is the most important structure which we must do, and especially the posterior osteophyte of the femur. So number one is lift it up well with a spreader, or take a rod inside the canal and pull it up and try to clear the posterior capsule. See that no osteophyte is there, especially on the posterior medial corner of the femur. The other thing, we do not try to go to tibia all around, but still we might be missing a couple of osteophytes on the posterior border of the tibia, which will be abutting around, or rather tethering the posterior capsule of the knee joint. So just when you subluxate the tibia, try to look around. The osteophytes, once we have cut the proximal tibia, they become very clear. They are delineated, so you can remove them. And all these things will lead to a very good stable joint. Thank you for this session. Questions we will be asking later on during lunch, and there are so many more sessions. You can have your own doubts, get it cleared by any of the faculty you want. Welcome to the next session now. And I really thank all the panelists.